read the fire procedures to you all. In case of an emergency, there are no planned fire drills this evening. If you hear the fire alarm sound, please treat it as a real emergency and evacuate the building via the nearest safe escape route. The nearest escape route is via the stairs to your left as you leave the council chamber or public gallery. Exit via the door at the back of the building and walk across the car park to the evacuation point, which is the pavement opposite the police station. The lifts can't be used in the event of an emergency. Please do not re-enter the building until advised it's safe to do so by a member of staff. We have no apology, which and no substitutions. If everybody is happy, we will look at minutes, which is page 5 to 10 in your paper. Is everybody happy that to the right? And I just sign yes.
But I will.
Is anybody? Thank you, Eva. Does anybody have any declarations of interest of anything on the Absolutely. No. I would explain for the first part of this meeting, we invited only committee that has a health scrutiny section. So when we have an overlap with other committees, invite them along. So we've invited people from Children's Committee. Just join in the first section of the meeting, scrutiny. Thank you for your time and taking on an extra meeting. That's appreciated. We have no public questions this evening, and we have no members' questions. Let's check the So we will move to number 6, which is the health scrutiny section. And tonight it will be regarding mental health support for young people. Basically, our remit was to be about accessibility, availability. I'm going to hand this part of the meeting over to. Don't even get excited. You don't want to be.
Chair, thank you very much. And thank you very much inviting us all along this evening. I wonder if we might just start by introducing colleagues who've come along for this item. So I'm Ashley Whitcomb, I'm the Director of Children's Services for the Isle of Wight Council.
I'm Callie Ware, and I'm the Children and Young People from Hampshire Island.
My mom, Meek, and I'm from the board. I just thank Joe.
So what we thought we'd do is we're going to talk for 10 or 15 minutes and we're going to talk to the slides that have been previously circulated, and then we'll be very happy to open it up and take questions on anything. So I'm going to start and then I'll hand over to colleagues to go through the slides. The 3 things I wanted to say is that, first of all, if you speak to children and young people, certainly when I go and speak to children and young people and I speak to families and we talk about things that are impacting their lives, what's going on, children's emotional well-being and mental health is right up there as one of the biggest concerns that people have. And it's very clear that needs relating to emotional well-being and mental health amongst children and young people are very significant and indeed have been rising for some time. And there's lots of different determinants of the quality of emotional well-being and mental health. Quite a complex landscape, but we know that needs are high. There's lots of children, young people and families who are very concerned about this area, which is why we're really grateful that you've highlighted this as a topic that you want to understand more about and scrutinise what's happening locally. The second thing I wanted to say is that many of you will be aware that one of the big areas of focus we have on the island about anything to do with children and young people is the importance of focusing on early identification of need, early intervention, and the prevention of the escalation of need. We know that it's absolutely in best interest of children, young people and families to be proactive about identifying need. And the earlier we can identify need, the earlier we can put support in place, the more we can prevent needs from escalating, the better for children and young people. And by the way, it's also cheaper in terms of the amount of support that families need. So we absolutely need to focus on early identification and prevention. And the other thing that's really relevant, linked to that early intervention piece, is that the voluntary sector play a massively important part in the offer on the island. So we're really grateful that Jo's come along this evening to represent what she does, but also to signal that the voluntary sector play an absolutely vital role in what we do in this space. And so the third thing really I wanted to say is that emotional wellbeing and mental health is an example of where no single organisation holds the key to the solution. Organisations need to work across organisational boundaries, whether it be the Integrated Care Board, the local NHS trust provider, the voluntary sector, and of course, earliest providers, schools, colleges. There's a whole plethora of organisations that play a role in this. And we're some of them, but we're not all of them. And we need to think about, as an island system, as one island team, how we can work together on this really important agenda, because no single organisation holds the key to the solution for this. We need to think about ourselves as one island team working across organisational boundaries in the shared best interests of children, young people and families. So I'll hand over, I don't know who's going to go first. Emma is going to go first, and we'll go through the slides and then we'll open it up to questions.
So yes, I'm going to describe our vision to you all, but actually done a really good job introducing some of the points around what's really important in our vision to us. When I say us, I mean system partners, NHS Trust, our voluntary sector, local authority, and all of our system partners. And we echo what Ashley just said, this is everybody's responsibility and we need to work together for this shift and move things forward in terms of what we need to do to meet the real needs of our children and young people. So collectively, we want children and young people in Hampshire and the Isle of Wight to absolutely have the best start in their life. We want them to experience positive mental health and enjoy their emotional health and well-being. By working really closely with our system partners, we want to achieve this vision by promoting the importance of partnership. I think most people understand that, but we can still get better at working really well as a system and seeing us as a collective system. We see this is everybody's business, as I've just said. We want to support professionals that are working with children and young people to have a shared understanding what positive mental health actually means and what does that look like. We want to ensure children and young people have access to a whole different range of interventions in real time and the resources to support their needs. And more importantly, an early stage, early prevention, early intervention, needs-led at a much earlier stage to prevent that crisis point escalation to our specialist services. We want a clear model of support for children and people that's needs-led rather than diagnosis-led. And we want to help support the children and young people, their families, the system and professionals, understanding what early help looks like, what that means, to again prevent that escalation to our specialist services. And we want to generally and collectively improve the access, the experience and outcomes for all of our groups of children, which we know have an increase of mental health. Thank you. So the next slide depicts our framework. This is underpinning all of our mental health work within the system. It's an I Thrive framework which promotes a needs-led, person-centred approach to mental health. It's got a strong focus on prevention and the promotion of well-being across the whole population. We use this framework, we're not just using this framework in the mental health world, we're using this in a lot of our other portfolios and work streams. it's a really useful framework to understand from early prevention to specialists in terms of what falls under those categories, to help understanding within the system our pathways. And we try to use pathways more so than services. As you can see, it's got the centre is thriving, that's what we want our children to do, and then it's got the categories around. Emphasis is placed on prevention and mental health and well-being as a whole population. Thank you. Okay, so we put this slide in just to demonstrate context across Hampshire and Isle of Wight against the England benchmark for our data. So this is just comparing the difference across Hampshire and Isle of Wight, Southampton and Portsmouth compared to the English data. This the data is just proxy data against the cohort of children that are most likely to be accessing our mental health services. And it just shows where we've got high levels of children where we want to target our support. The data that we have and that we're collecting across the system, across the footprint, just reinforces the need to focus on early help and prevention and make system-wide changes by focusing on different early help pathways. For example, My Happy Mind and MHSTs. So I'm not going to go into the detail of that. Just the con.
Thanks, Emma. So this slide just talks about the delays and what's the impact of delays on accessing mental health for young people. So there's short-term impacts and long-term impacts. And it's just really important to consider how those will impact young people long term, and think about how critical it is to have early intervention in place. And the longer the delay, the deeper and more lasting the impact. So it impacts young people mentally, socially, academically and physically. So I just wanted to highlight this to everyone in terms of consequences. So this slide is a picture representation of the current model that we have on the Isle of Wight for mental health support for young people. So we have 3 main tiers of intervention currently, which are the mental health support teams, which I'm going to talk about in more detail in a minute. Youth Trust, who offer a counselling service, which Joe's going to talk through, and also Bernardo's and AMS. So for young people who have mild mental health concerns, they can access support through the mental health support teams in schools, and also CWPs and Youth Trust and Bernardo's. Young people who have moderate mental health concerns, they can access the Youth Trust. For children who've got complex and severe mental health concerns, PAMS will be able to support, and this can include support around self-harming, suicidal thoughts and eating disorders. And all these teams work with young people who could have a learning disability or a neurodiversity need and a comorbid mental health condition.
This slide is an example of many mapping exercises that have taken place across our system partners and collectively as a system. It demonstrates that we've kind of done some work under the 5 categories of the iThrive model, and they are thriving, getting advice and signposting, getting help, getting more help, and getting crisis and risk support. Work that's been done just shows some of our pathways under each of those headings. This is an example of exhaustive and work that's taken place over Hampshire, Isle of Wight, Portsmouth and Southampton. Can't actually see tiny writing in the slide, but for example, you've got getting help has talking therapies, you need them. Getting advice and signposting includes that universal kind of support and how. Thriving, I'm sure you've all heard of Be Well by now. That's one example of what would fall in that category. And I will leave it there for a moment. That's just putting in context that work has actually taken place to map out our pathways under each iThrive. And there's more work to be done about that, but we're getting a really good understanding across the whole footprint that fall under those categories.
if I can talk about young people who would benefit from getting some advice and some help. So we have the MHST, which is a mental health support team. So the MHST is a collaborative, which is made up of the Isle of Wight Youth Trust, Barnardo's and Hampshire and Isle of Wight Healthcare NHS Foundation Trust. And all three providers work together on the island. So the aim of mental health support teams is for prevention and early interventions and treatment of mild to moderate mental health conditions. So the team is based in schools, so they cover secondary schools on the island, apart from the private schools in St Catherine, and they're currently in all primary schools, bar 2 primary schools. So they, depending on, so in primary schools, they will do a lot of work around whole school approaches. So there'll be support teachers, there'll be support parents, they'll be running groups, they'll be doing assemblies, and they'll be working with the school in terms of how they can improve their kind of mental health and well-being within the school. So it's a whole school approach. They also work in secondary schools, so they do similar things. So they will do assemblies, but they will also do one-to-one work for young people as well. The feedback from this service has been extremely positive in terms of young people engaged with the service and parents. They currently do not have a waiting list, so they see young people fairly swiftly. They are doing some work around transition, so supporting children transitioning from primary school to secondary school, and also running some groups over the summer that families and children access. That's really positive. And then, Jo, did you want to talk about the Youth Trust?
Yes, so a little bit about the Youth Trust. We were contracted by the Integrated Care Board to deliver the Tier 2 element. It's called a counselling services contract. It's aged, or it supports children aged 5 to 18, but up to 25 if they have additional needs. The contract duration is 4 years plus 2 optional, and that commenced on the 1st of April 2023. Although it's called counselling service, the therapies that we can offer are much wider than that, and include CBT, cognitive behavioural therapy, DBT, EMDR, art therapy, creative therapies, and we also have a specialist IAPT autism worker too. We undertake specialist group work, for example, tics and Tourette's, plus we deliver parent workshops to support their children, particularly whilst they're waiting for support. It's true to say that demand exceeds the available resources, and there is a waiting list for that service. Alongside the therapeutic work that we offer, you may have been aware that we have opened something called the Hub. It's broadly for the 16 to 25s. It's funded by the DWP, Sovereign Network Group, Integrated Care Board and others. And it's about creating those pathways to independence and enabling and empowering children and young people who are 16 to 25 to look at building happier, healthier futures. So it's not getting stuck in that transition into adulthood. Although that is a universal offer, just as counselling services, we do target and focus on particularly vulnerable children and young people. So those who are care experienced in the youth justice system, who are homeless or at risk of homeless, and those who are not in employment, education or training. So yeah, it is a universal service, but it's absolutely targeted. I did just want to very quickly, before I move on, talk to you about some of the outcomes that we achieve. So in 2024-25, the Youth Trust received 1,745 referrals, and we delivered in total 7,912 sessions, and that's either one-to-one or group work, and that's across all of our services. Focusing in, because I was conscious that this is also an adult committee focusing in. Housing support was provided to 65 young people, and employment and training support was provided to 369 young people. From a therapeutic perspective, 79% of those in therapy made significant progress in their outcomes, and we achieved a client satisfaction rating of 90% of those young people who gave us feedback scoring 7 or more. At a recent DWP summit, so there was a DWP summit in Swindon, who knew? But one of our workers, Matt, who leads the hub work, was asked to go up and talk. And as part of that, it became apparent that nationally, using the traditional DWP model, the conversion rate, i.e. those young people who are not in education and employment training, is running about 6% into work. We are currently running through our model at 58%, which is absolutely, I'm really proud of that. It's phenomenal. I won't give you the quotes, but we have this year also been a winner of a national prestigious award, which is for the King's Fund and GlaxoSmithKline, GSK. And the final thing I really wanted to say was that through everything we do is the golden thread of youth engagement. So we do have the value that there are no decisions about us without us. And so a significant level of co-production is carried out across the piece. So just to give you that information too. Thank you.
Thanks, Jo. I'm going to move on to talk about CAMS now. And I know there's been a lot of information in the press in terms of CAMS and CAMS waiting lists. So on the Isle of Wight, CAMS service, we work with 0 to 18-year-olds and their families who experience emotional and mental health issues. The team is made up of, we have a eating disorder team, we have an in-reach outreach team, which is our crisis team, we have family therapy, psychology, psychiatry, and also psychotherapy. We also have a consultation, partnership and liaison team within CAMS who can work with professionals in terms of any advice that they may need to support young people. The service works with young people who require a specialist provision, who've got quite severe mental health concerns and risk-taking behaviour. The team's made up of nurses, psychotherapists, family therapists, psychologists, CBT therapists, occupational therapists, social workers, psychiatrists, nurses. So it's very it's an MDT team who work with the young people under CAMS. Any professional or voluntary sector employee can refer children and young people to CAMS, and also parents, carers and young people can also contact us and discuss how what support they require and how we can support them. We also accept self-referrals from young people. We've recently introduced 2 innovative teams to Isle of Wight CAMS. So we have a holistic at-home treatment team. So this team was introduced a couple of years ago and works specifically with children who either have an eating disorder or are in psychiatric crisis. So previously, if young people became really unwell on the Isle of Wight, they might need a Tier 4 inpatient bed admission on the mainland, which obviously is not good for a young person to have to travel so far or be away from their community, be away from their family. So we really invested in this team, and we've managed to reduce the number of young people who've needed to go to mainland placements, which has been really positive, so we can keep young people at home in the community with their parents. And that team has done intensive support at home. So if young people have got an eating disorder, they will go into the homes of the young people and support parents in terms of encouraging eating, things like that. And the second team that we put in place is a peer support transition team. So this is a team of peer support workers who've experienced mental health issues and work with young people to transition them from children to adult services, because obviously the jump between children and adult services is quite big, and they work in different ways, children's services and adult services. So this team can specifically support young people to make that move. And we've also worked really closely with the Youth Trust and Isopropia to put a group programme in place for 16 to 25-year-olds as well. Because we've also really wanted to, instead of young people needing to go into secondary mental health services, look at whether they can access community services instead, or voluntary sector services instead. So in terms of our assessment waiting times, so in May, the average wait for assessment was about four weeks. We pride ourselves in the island in terms of being able to see young people quite quickly. There are delays sometimes in being able to see young people, and this is usually due to if a young person DNAs their appointments, or if patients cancel appointments. That can mean that waiting lists are a bit longer. Also, we have some young people need to be assessed by a specialist clinician, and we have limited specialist clinicians on occasion. So if young people do have to wait a little bit longer, that is usually why. And then going on to talk about risk support. So we have a risk team within CAMS who support children who are at high risk, who are self-harming and need to hospital admission. And then also within ED, the ICB commission a no limits service. So they work with young people who have presented in ED, if they've attempted suicide, if they self-harmed, if they have anxiety, and they will work with the young person to consider what could be done in the community in terms of social prescribing. So that's been really helpful as well. And then finally, we just ensure in terms of all the services, it's about working with other statutory services. So like I've talked about, we support young people to transition to adult services. We work closely with children's services, so children who are under early help, child in need, or child protection. We also work closely with local authority in terms of EHCPs. We work closely with schools and teachers to think about how they can support young people. And also we work jointly with children's therapies colleagues, and also we are part of the neurodiversity MDT. And then we always encourage young people to engage in community services, so Network Ride, Army Cadets, Autism Inclusion Matters, and the new Youth Club, which is in Newport. And then finally, this slide just talks through, and I'm not going to go through it, in terms of if a young person does not meet the criteria for CAMS. So every week we have a MDT triage meeting where referrals that come into CAMS are discussed. And on that, in that meeting is Youth Trust, Bernardo's, and the mental health support team. So we try and think about the needs of the young person and where those needs will be best met, whether they can be met with the services that we have on the island, or whether we need to refer them on to more specialist services. And we try and make sure that they're supported through that process.
Thank you. We're now going to open it up to councillors for their questions. So the first one to put his hand up is Councillor Nicholson, and then Councillor Lever.
I must say, I found having to listen to all those reports and about what we're doing very frustrating, because you're all from service industries, service areas that deal with the situation after the horse has bolted. And I didn't hear anything in particular about prevention, dealing with let's face it, the children's mental health is a product of our society. You've only got to look at other areas, childhood obesity, low aspirations that we suffer from on the Isle of Wight, high rate of illiteracy, poor employment. All these socio-economic factors can be addressed, and they should be addressed at a strategic level. So have we got a strategic economic plan in this council? No, I don't think we have, not one fit for purpose. Have we got a director that deals with it? This is the sort of level that we should be dealing with these, dealing with the root cause, not accepting that it's a problem. And all of you do a fantastic job, and it's really great to hear what you do. But it's after the horse has bolted. And one of the things that might empower young people to help themselves is an understanding of how the mind works. And when you're a young person, it can be very, very confusing because your emotions are running riot. And I know Hampshire at one time engaged Steve Peters with his chimp model in the schools, and we tried to do it over here with great success. And I haven't heard anything about empowering young people to understand how their minds work and how their own emotions work. So that's my take on it. I found it very frustrating because we're not dealing with the root cause.
I think we have Joe Dare put hand up to respond, and firstly.
Councillor Nicholson, first of all, can I absolutely 100% agree with you? Not necessarily about the frustrating bit, but absolutely we have to get to the root cause of the challenges and the decline in children and young people's mental health. There's been recent research by the Young Futures Foundation. They have just published a report that that research was undertaken by the University of Manchester and UCL in London. And they looked at 10 different determinants of why there's been such a decline. And over time, they've come to the decision that there are 4 that are particularly important. And I'll just read them to you because I think they do echo very much what you are saying. So number 1 for young people in particular is that whole issue around employment stability, that's if you can get a job, and then the pressures of affordability and going on, whether that's affording a tenancy, clothing, housing, anything that you care to mention that you have to pay for as a result of the money that you have. And I thought that was very interesting, and I think that links into some of the work that we are doing in the hub. So through our DWP contract, we cannot get to work with young people until they have been 13 weeks in that NEET state, not in employment, education or training. By 13 weeks, some of those behaviours have become quite ingrained, and it is harder to work with those young people who are very vulnerable. So, but that's the contract and that's what we work to. The other 3 I'll just very quickly touch on. So one is around declining sleep quality. One is around social media and smartphones, which I'm sure we would all recognise. And the final one is around reduced children's and youth services, which, without making a political point at all, this is a funding point. The local authority has not been able to afford over some period of years. And the point about youth services is that they gave children and young people the ability to have a trusted adult, so that there was always somebody to turn to try and prevent that escalation into poor mental health. Now, we do have some really good youth services that are now delivered at town and parish level, but they're a bit of a postcode lottery. So some children can access them, some can't. So I thought that was really interesting research.
Joe, a lot of what you said are place-based solutions. They can't be resolved entirely by the Isle of Wight Council or by overall services. They have to be enacted by the community, and there are place plans in place on the Isle of Wight, and I think to give those place plans support and guidance on how to deal with health and wellbeing issues would be very, very supportive. It would be a good investment. But I think that from this committee, that a recommendation needs to go to the directorship of this council, that we need to have a fit for purpose economic strategy overseen by a director with the right competencies. And that is that affects the whole of the Isle of Wight.
Thank you. Councillor Lever.
Yeah, there we go. Thank you. Thank you, Chair. I'm just looking at the table of differences compared to England, and I like data, so I was very interested and intrigued by this. So the only thing I was thinking about was in the roundabout delays, do we know or can we calculate what proportion of these numbers can be attributed directly to or being exacerbated by delays in treatment? And is it possible to sort of model risk outcomes by the length of delay? Sorry.
Who'd like to answer that one?
Sorry. I think that's probably something that we need to take back and look at and see if we can answer that in writing to you. There is, I mean, I'm thinking of my colleague who's also a data, he's really data driven, and he probably has done a bit of a deep dive into that and will probably be able to answer you quite clearly. So I'd like to take that back to him and see if I can get something in writing.
That'd be fine. If you email to me and then I'll share it with all of the committee.
The question will be captured, but in terms of, yeah. May I respond to?
Of course you can.
I just wanted to touch on something you said, if that's okay, Councillor Nick, and about strategically recognising the earlier intervention and prevention, and not in terms of an economic strategy, but around what we're trying to do as commissioners within across the footprint, recognising that actually there's much more to do at a really, really earlier stage. At the moment, we're commissioning programmes such as something called My Happy Mind. I've actually been in a scrutiny committee meeting before and shared the programme, and it's very much about supporting children, young people to understand their mental health, what positive mental health looks like, and enabling them to thrive. It's a whole school approach, and it's from preschool right through to year 6. And I'd be happy to share more information about that, because that is something that we're implementing across the footprint. It underpins, think of the triangle of support for mental health: My Happy Mind, early help, support intervention, MHSTs, counselling, talking services, and more, as Joe described, and then CAMS, and then Tier 4. It is the baseline of support that we're trying to inject into the system, and we're starting to roll that out and gathering impact and evaluation reports, and I'd be happy to do more on that.
Next on my list is Councillor Andre.
Thank you, Chair. If I may, I have several questions. Can I ask? There's no doubt that there's some extremely good work going on here, but certainly, oh, hang on, it's that, isn't it? But certainly, just listening to it, if I was a young person wanting to access the services, it is confusing. Some really good work was done in adult social care on a very similar issue to try to provide, well, it was no wrong door, but it was one front door, and that's been really successful. So that's my sort of first question is, the councillors we know have duties and responsibilities in terms of our young people and their mental health, and especially with young people with special educational needs and disabilities. And we know that there's, from the data, that there's often a higher proportion of those people, that cohort, that need our support. So is there a possibility that perhaps the council or one of the organisations could be the lead organisation, so that we could actually have a single point of access for that young person? So that's the first thing.
Can we just let this one be answered?
That is what is being thought about at the moment, because it does appear to be a minefield, doesn't it, in terms for young people? What do I access? How do I access that? So we're doing some work with the ICB and providers as well on the island to look at, could we have a more streamlined way of accessing services, so like a single point of access. And we want to engage with young people as well and parents to get their feedback in terms of how they would find that experience too. So yeah, we are looking at that at the moment.
Councillor Andre, your next question.
Thank you. So my next question is, so we've heard quite a bit about iThrive. Is that, I'm not quite clear, is that a system that is ICB led? Is that a system that all the partners are actually buying into?
Yeah, it's the I5 model is kind of a national model that nationally we're looking at in terms of mental health framework, and we have been working with the ICB in terms of that framework and how can we embed it into practice on the island as well, and also had discussions with the local authority in terms of SEN and children's services to think about how we could make it a common language across the Isle of Wight, LA.
So what I'm thinking is currently it's a work in progress. Can I sorry.
Language that we're all using as system partners in our framework that we're referring to.
Okay, I will, my final question then is, I know through my own experience of being involved with the family hubs as cabinet member, that there is often some confusion over the thresholds for the tiers. And as we've seen, it's different organisations offer support within the different tiers. So, and I know historically there has been a little bit of young people being passed from one organisation to another. And I know it's a complex landscape because obviously their condition, as we've said, if there's been a delay, can be exacerbated. So it is a difficult area, but how is that process determined as to which tier and which support that young person is going to get? Thank you.
Councillor Andre, so although we are not yet at a single point of access, we are very much a collaborative point of access. So weekly, there are meetings which are triage meetings to determine exactly what you're saying. And although those meetings happen in our specific tiers, they are joined by members of senior members of staff from the other tiers. So in reality, behind the scenes, then we are talking a lot about which is the right pathway for a young person. Added to that, we also have something which we call internally, it's not an external thing, step up and step down. So if a young person comes in at a level and their needs escalate, they can be moved into a different pathway very easily. And then once they're ready to become more independent, but perhaps they're not ready to kind of let go themselves, then we talk between us about how do we move them between the services to provide them with a bit of that ongoing support for a bit longer.
Next on my list is Councillor Lilly.
Thank you. Councillor Michael Lilly, I'm Vice Chair Children's and also the Isle of Wight Council Mental Health Champion of a particular interest. I'm glad Councillor Andre brought up about thresholds. My particular thing is when you looked at the figures up there, you saw a lot of red of the Isle of Wight. And if you actually broke down some of those figures, we have some of the worst figures in the UK of young people. So it's not a question of the horse has bolted. It's gone a long way.
And those young people need sort of resources now. And because you end up focusing resources, then other young people, it's harder to do the prevention side. So I want to know really about the voice of the young people, because the voices I hear are from families, and particularly we've had a number of tragedies where young people have died through taking their life, etc. Is they basically said we communicated early on that we needed help and we didn't get it. And I think you could fill this room with aggrieved families in current situations. You could absolutely fill this room. And if you look at the data coming from Health Watch, right, and your data as well, you have got a difficult thing. So we can't rosy it. We need to be looking at how do we tackle and get the young people that are at the level 4, right, there, but also on the threshold thing, make sure that we haven't got a huge queue at 3.5, right, which actually go, because that is the reality of what is actually happening on the island. And I don't think we've really got to, the figures speak for themselves in that. So what is the short-term plan, right, and the long-term plan in bringing those figures down, and also making sure that people don't get past level 1 and 2, because that's where we need to do. And I would say the point about the youth services, there's been a marked difference in the areas where you have got good youth services, like in Ryde now and Sandown, where you've got good youth services, the figures are down. And I think it'll be very useful to have an area comparison of those figures across the island to actually see that, right? Because you've got to have good youth. The trusted adult point that was actually raised is extremely important. Thank you.
Right, I hand it over to you guys to pick out which bit of that is a question.
That's the vision.
But I can provide you with some information. So I think the point is well made that prevention and early help helps to stop escalation into tier 3 and worse, tier 4 inpatient support. So I think that's a given, and all three of us would agree with you. I can only talk, and I'm only prepared to talk from a voluntary sector perspective right now, that I think we need to think about how do we shift some of the resources that we do have, because there is not an infinite pot. But what I can say to you is that at tier 2, we are getting referrals at a rate of, well, June was 98 referrals in the month. The highest we've had was November 2024, when it was 147. So those referrals are coming in like constantly. There is a constant level of need. And as a result, our waiting list is currently, as of today, 422 young people. And that equates to 93 across under 11s, 290 the 11 to 18s, and 39 18 plus. And those young people have to wait. And this is our estimate. This is just our estimate. If we had no new referrals at all from today, it would take us to the end of January probably to get through that list. So with ICB support to support risk management to our organisation, we have paused referrals for under 11s, and there is always then the support via MHST in schools. But unless unless we find more money or we find a miraculous way to shift resources in a way that we just can't do because the need is also at tier 3, then I think it's a really, really difficult situation.
Thank you for your honesty. Councillor Fuller.
Thank you. Again, I've had a lot of questions that have already been answered, but certainly one of the things that I wanted to raise a question was that waiting list. It's not acceptable. It really isn't. These are young people. These are our futures. We don't have a great track record with young people on the island. We have a lot of young people that leave the island because they're fed up with the island. They don't feel that they're being looked after. They don't feel they're being cared for. They're not getting supported. And I think this is an example that we can give as a council of us not actually stepping up to the mark and supporting our young people. How can we, what is our plan for dealing with it? Obviously, getting money to be able to spend that is hard to come by, but it should be a priority for us. It should be a priority for this council moving forward, and it is just totally unacceptable. And I hear what you say, but that doesn't actually cut down on the waiting lists. And I'm hearing no plans to be able to do anything to address that matter.
Do you know, I always like the fact that Joe's always happy to answer something. Go on, Joe.
Well, again, I can only talk to you from our specific service. So we recognise and we would agree with you that it is unacceptable. And we have worked with our colleagues across the system to try and introduce some different ways of working to try and reduce that waiting list. So, for example, we have increased our offer on small group work. So instead of every child coming through and seeing somebody on a one-to-one basis, can we offer a 1-to-3 basis or 1-to-6 basis? That has some success, but a lot of young people themselves are saying we want one-to-one. And I think that's probably one form of innovation. I think another way that we're working really hard together across the team is to say, have we got, when a young person refers into the Youth Trust, perhaps because they know the name of the Youth Trust and so that's where they start, that triage process of saying, is that young person in the right place and could they be adequately supported through another service? So there are ways that we are absolutely attempting to manage that demand, but it's hard.
Can I apologise, please, Chair, because I felt that was being quite harsh to you. It's just something that makes me very, very angry that, year after year after year, we're told that these structures are in place to support our young people, and things don't seem to be getting worse. And I think the fact that we've got 400 children on our waiting list is really, really very difficult. And I think there is an expectation that we as a local authority should be trying to do something to address that. And again, I know that the children's committee, as well as as the adult services committee, feel probably in the same way that something needs to happen, because again, a lot of the problems that our children have also come from parents as well, and their parents are also in chaotic circumstances, and they need the support that ain't out there, because we just, we're not receiving that. But it's not just about not receiving the money, it's about trying to look at a plan, see where the best practice is elsewhere, and trying to replicate that to the advantage of our young people that are falling through the safety net. Thank you.
Thank you, Councillor Fuller, Mr Whitaker, and then Councillor Redrup.
Can I just give some more examples of what is happening actually, in addition to what Joe said around addressing the waiting lists? How do we stop the waiting lists from occurring in the first place? And it is back to think what Councillor Nicholson was saying at the beginning, but just to give you some assurance, there is actually a lot of work going on to at that early stage to prevent these needs in the first place. I'll give you 3 examples. So we know that, and Joe went through the recent report, so there are lots of different determinants of poor mental health. We know that what happens in school, in mainstream schools, is a big factor. We know that if a child is not having a good time at school, if their needs are not being identified at school, we know that that can result in poor mental health. So this is very much linked to the education strategy that the island now has, an education strategy through till 2030. And we believe now that the work that our school improvement team is now leading on, been in place since April, as we work with our schools to improve wider education standards, that will have a positive impact on children's emotional wellbeing and mental health, because we do believe there's a correlation between experiences in mainstream school and mental health. The second example I would give, and this is another example of where we rely on lots of different organisations and bits of organisations. So public health, I can see that Simon Bryan, in one of his last meetings, I guess, for this council before his service comes to an end at the end of August, but public health play a massive role in this arena. And I'm thinking about the Peach programme, Partnership for Education, Attainment and Children's Health, which Emma has spoken about in past scrutiny meetings. But this is around looking at, taking a public health approach to children's wellbeing in schools, and it's looking at the link between physical health and mental health. And I think the more that is rolled out and embraced by our schools, the better, because we believe that will have a positive impact as well. Some of you, I know Councillor Lilly, I was delighted he was able to attend. We held a conference called Together for Children back in June. And what that was aimed at was bringing, and I'd like to thank the former High Sheriff Graham Biss, who led on this and continues to lead on this work, recognising the role of the voluntary sector in this. We brought all voluntary sector organisations that we could get into one room. Not everyone came, but many did. We have about 120 people in the room for the day down at the Riverside at the beginning of June. And we were focusing on this issue of early identification, prevention, and the role that the voluntary sector plays in it, because we know that trusted adults and many of the activities and the structure that voluntary sector organisations give to children and young people is massively positive for children's wellbeing and mental health. So that's something else that's going on, and that will continue. It's already been agreed that will become an annual. This is based on feedback from delegates at that conference. It has become an annual event. We will continue to work with our colleagues in the voluntary sector across the whole island to help them thrive, so that they can support children and young people. And if we can just go through three other things, specific examples around actually children coming into the child protection arena, because we know that there's also over-presentation of poor mental health amongst children in who are designated children in need or in the child protection system or coming into care. We think about what are the main drivers of children coming into the child protection system. For the first time nationally, this is now adult mental health needs are the single biggest determinant of children coming into the child protection arena. So we need to work with adult mental health services as well, because that's a key factor. The other two big drivers are domestic abuse. We know that there's a new domestic abuse strategy for the island, and we need to get behind that. We need to embrace that, because that can have a big factor on the experiences of children in those households. And we also need to think about substance misuse, which is the third biggest driver. And again, public health lead on that. So we need to work really closely with our public health colleagues on that. We look forward to working with the new Director of Public Health when she comes into post at the end of August. And there are things like the poverty strategy, which the island has now. We know there's a big link. Joe referred to it. The link, if you're in a household that is struggling with the cost of living, unstable housing situation, etc., we know that has an impact not just on parent mental health, but also children's mental health. So I want to give just some assurance. It's complicated. There's lots of different organisations involved, but there is a lot of work happening to try and shift the focus to the early identification and prevention, as opposed to dealing with 400 children on a waiting list.
Thank you, Councillor Redrow.
Thank you. Thank you very much for coming and bringing this presentation. And it's really interesting to see that the breadth and variety of different things that are on offer for young people. I had two specific questions based again on the red boxes. I'll try and be quick. So firstly, I just wanted to look at the pupils with special educational needs is 23. It's higher than our peers in the region and also higher than the average in England. There was a mention of EHCPs earlier when you were presenting, but I was wondering if you could give a little bit more detail about how the NHS and ICB are ensuring that children and young people with those special educational needs are receiving the statutory support at the moment, how that's going, if there's any KPIs, how we're meeting them, that kind of thing. Thank you.
We recognise that there's much work to do around DHCPs and statutory duty. We've got a specialised DSL at the moment that's actually looking at auditing the current processes and our EHCP system and making sure that the two elements, the education and the health element, are doing what they should be doing. We'll take the learning from that and we will be using that to improve the processes and systems around EHCPs because we recognise it needs to be better. Did you want to add anything to that?
No, just that obviously we are linking with say that, what?
Yes.
Yeah, we are linking with the DSL in terms of EHCP provision. So she's working very closely with the local authority, and then she works under the ICB, and then she will liaise with us in terms of providers, in terms of what we're offering to young people who've got EHCPs. Also, we will input into EHCPs, so we will often be asked for information if a young person is open to the service or whether the young person requires assessment with the service. So we are working towards kind of better relationships in terms of working with the SEN department.
Oh, make it quick because we're tight for time.
Yeah, I think we're sort of missing the point here. I don't believe for 1 minute that Isle of Wight children or adults come to that are born any different to any other babies in this country. All this happens in their development, and it's symptomatic of other areas in this country which are socio-economically deprived. So that's where the core issue lies. And I'm looking at Simon to agree with me because we've had this conversation before. And that's what needs to be addressed. So it's all very well having an educational strategy, and I know Ashley gets it, but an educational strategy for what? What are we educating our children for? The whole thing tears down from an economic strategy. An economic strategy drives socio-economic environment on the island, and we haven't got one, not one that's fit for purpose, and we should have.
Councillor Nicholson.
So,
we don't need one just yet, but I get it. Councillor Redford.
Thank you, thank you. Yeah, I'll be very quick. So one of the sort of scariest part on that list of the red boxes is the hospital admissions for self-harm and hospital admissions for mental health conditions. I was wondering what targeted action there is to address that, and also to understand who these children are and young people are that are coming into the service. And I would have liked to see perhaps some demographic data to try and to understand that a little bit more in this. I'd like to answer that.
Do you want me to pick
I
up that
think
question
it
on
is
data?
really high when you look at the numbers in terms of presentations to hospital for children who self-harm. So what we talked about today is making sure that there is early intervention in place, for example, through the mental health support teams, through the youth trust, and then obviously if more intensive support is needed through CAMS. So what we've worked really hard with CAMS, and especially with the holistic at home treatment team, is to try and reduce the number of children who represent to hospital as well. So ensure that they're getting really good intervention in place so that they're not often going into St Mary's because they've self-harmed. I think there's been a wider conversation in terms of with public health, in terms of thinking about how we can look at reducing the numbers of presentations to A&E for children, and also the introduction of no limits with they offer the youth service in A&E, so they can work with young people in the community, so engage young people in community services, so a bit like social prescribing. So that's also been kind of really helpful and really beneficial. And I think we can definitely look more at the demographics in terms of presentations, and if there's specific areas on the Isle of Wight where young people live that are presenting more about, do we need to do some targeted work around that?
Just going to bring in Simon Bryant, and then we will hand over to a question from Councillor Lever. So Simon Bryant.
Thank you, Councillor Morster. I was just going to bring in the issue of the data. If you're
Can't
very
hear you,
careful,
Simon, it's your last meeting and all you're doing is moving your lips.
I've just unplugged my
No, still
headphones.
can't hear you.
No?
I don't know why it's not working.
That work?
It does say that you've got access. Try plugging your headphones in is the kind advice from Laura. Does that help? No, he's muted.
Any better?
Let me move to Joe Lever while you have a fiddle with what not working.
My end.
No. No, sorry, Councillor Lever will hopefully come back to you, Simon.
Thanks, Chair. I've got two questions, if that's okay. The first is around, I was looking at mental health support teams in schools. I was just wondering, and apologies if I've missed this in the presentation, but what is the support for children in non-formal, informal settings as opposed to schools? I'm thinking about, we've got a high home educated population on the Isle of Wight, and in particular, something Mr. Whitaker mentioned before was specifically around those that have actually left mainstream settings because of poor mental health support, then moving into that space. What's happening there?
You'd like to answer that?
I can answer that. So in terms of the home educated cohort of children, the MHST is just in discussions at the moment with the local authority to think about how they can reach out to support that cohort, because obviously it is quite a large cohort of children on the Isle of Wight. So that's in progress at the moment, and they're hopeful to be able to put something in place in the autumn term. Consider they could look at. And then the other part of the question was about children who disengage from school. So I think all of our services would probably work with children who've disengaged with school. So I'm sure Youth Trust would have children who are under them who aren't attending school, and then also at CAMS we work with young people who are attending school. So often young people can deteriorate quite quickly if they don't attend school and are not leaving the house, have high levels of anxiety and things like that. So we've had to do some quite assertive outreach in CAMS to go to young people's homes, work with them, encourage them to think about attending school. And it's also about working with the local authority as well, the SEN department, think about these young people's needs and how they can be met in the education system, and then how we can support in terms of mental health support as well.
And then similarly, thinking about people that transition into one service to another, what happens when a young person who is perhaps waiting for a service then becomes an adult? What does that transition phase look like? Do they stay on that track, or do they move on to a different?
So that's a really good question, because obviously we could get a young person who's referred to CAMS at 17 and a half. So it's thinking about really the needs of that young person. If they're going to need long-term therapeutic input, it wouldn't be sensible for us to start therapy with them at CAMS and then transfer them to adult services, which actually have quite long waiting lists for treatment. So what we do is, with the peer support workers that we've got in CAMS, we look at the young people who are probably 17 plus and think about their needs and think, would they be better suited to go straight into an adult service? And we try and work quite flexibly with adult mental health services on the Isle of Wight. So talking therapies will start working with young people from 16 plus. Ethiopia, who have also talked about with Youth Trust, run a group for children and young people who are 16 plus up to 25, and secondary mental health services like Branchry House will work with young people before they're 18 as well. So we just try and work flexibly, think about the needs of the young person. I mean, if a young person is open to CAMS in therapy, and we keep them on until they're ready to be discharged from that therapy. So sometimes we keep a young person on until then, just before their 19th birthday, so we don't have any disruption in therapeutic input.
Thank you. I'm going to try again for Simon Bryant to see if we can hear him, and then I'll hand over to Councillor Price's question.
So I switched to my phone. Does that work any better?
We still can't hear you, Simon.
It's not me.
Councillor Price.
Thank you, Chairman. Something I just wanted to mention and ask a question about, being a governor and at a primary school and having two children that I would say were quite badly affected during the sort of COVID pandemic. You know, it's something that doesn't really get talked about much anymore. But as a governor, we often talk about it because there are massive issues with regards to children of all ages, probably from 2 to 18, actually, that have got segments of their social development missing. And that might be just going to, you know, a load of babies all meeting up when they're toddlers and interacting with older children, to maybe siblings at school that couldn't, you know, when they get to school, they weren't allowed to interact until the end of the day. And then there'd be a big argument. And I'm not talking from experience with that one, of course. But there's, you know, there are, I would say that there are social and home and family life issues, behaviour, discipline. It goes on and on and on. And we can't forget that from sort of March 2000, probably up to probably the end of 23, any child that was, you know, I would say from 1, who are, of course are now reception age kids in September, are going to have some kind of effect. And I think it's going to go on for a long time. And I think lots of things have changed with the way people interact their children, you know, the kind of kids' parties that were happening when my children were a bit younger, they don't seem to happen now, for instance. The teenagers' parties, there's certain types of things, but it's not the same anymore. There's lots of things that have changed. And I think that that has now become the norm. And I think it has broken elements of children's, it's my opinion, but it's broken elements of children's development. And I just wonder, so the question really is this recognised with any of the ongoing strategies that are in place now? Has it taken, do you think there's an effect, and lots of these issues with young people have nosedived because of the pandemic and the things around it? I'm not just blaming the pandemic element of it, but all the things that changed and how it affected the way kids interacted around that time. You know, those are really the two questions. Do you think there was a nosedive from then? And that's something we can't put right, but also, is it within any of the ongoing strategies? And recognise that it's going to affect kids that are just going into reception now. There will still be an effect on those kids going forward, and the ones that they're already going to interact with when they get there. Thank you.
Thank you. I'll bring you in to answer that. And just so you know, the running order and what we're doing is, once that question's answered, we're going to move to Councillor Adams, and then I have Joanna Smith, and then we will end with Councillor Gladwin, and then we'll move on to the next section of the agenda. Okay.
So
Sorry, can I just ask, are we going to have the opportunity for recommendations?
Of course.
Thanks, Councillor Price, for the question. Maybe I'll start and then your colleagues want to answer. I think that, yes, it is absolutely recognised, and I think you've described the situation very, very well. You're right, the impact of COVID doesn't get spoken about necessarily every day, but I think we're all conscious of it. People, whether you're in schools or you work in other bits of children's services in the NHS, I think we absolutely agree with everything that you said about that. In terms of, is it included in the strategies? As Emma said in her opening remarks, actually, I think we're focusing on needs. We look at the needs of children. And so from that perspective, it is picked up because we look at the needs of children, and that's what then determines the intervention that happens, whatever the cause is. So we don't necessarily wait. We try not to wait for a diagnosis, an exact description of why something has evolved and what exactly the diagnosis someone has. We look at the needs of that child and try and treat the needs of it, and that's for various different reasons. And I think you're also right to say that it's not just COVID. I mean, there's been a massive change in parenting for lots of reasons, and part of it might be linked to cost of living, poverty situation. at the Together for Children conference in June. I don't know if you were in this conversation, Councillor Lilly, but there was a fascinating discussion I was part of in a group where people were talking about the use of mobile phones by mums and dads and how they are very free with allowing very young children to spend huge amounts of hours on a screen, and what is the impact of that on children and behaviour. So I think it's complex, it's absolutely all recognised, and we focus on needs rather than the causes of it. But having said that, we know that causes is linked back to Councillor Nicholson's point, and we're trying to do that as well. So it has to be multifaceted what we're doing about it.
I was just going to refer to the NHS long-term plan. It does talk about COVID legacy. It does talk about the pressures of backlog on all of our services within the NHS. It does also reflect on mental health services. And one of the recommendations in the long-term NHS plan regarding that is full coverage for MHSTs by 29-30 to try and get all schools having support and children and people accessing that support. So I would defer to the NHS long-term plan in terms of from a health perspective.
Yeah, no, and I think it's thinking about, I can give specific examples in terms of what we did. So when in COVID, we noticed a huge increase in young people who had tics and Tourette's, which we hadn't had before. So we were quite dynamic and worked with the Youth Trust in terms of putting a joint pathway in place to address those children's needs, because it wasn't something that we were getting many referrals for. And then during COVID, the referral rate for them increased a lot. So we tried to make sure, look at what the needs of the children had when they were coming into services, and then putting pathways and interventions in place to meet those needs. And it was really good because we were able to do it jointly with the voluntary sector as well. We put some groups in place. Good.
Thank you, Jo. 40% of our referrals are related to anxiety, and we have an increasing number of referrals that are related to anger as well. And I'm sure there is a connection. The anxiety covers everything from the education challenges that children are finding, that Mr. Whitaker mentioned. Social media is a big one, but undoubtedly that breaking connection between the emotional and social development of children and young people had an impact.
Thank you, Chairman. Thank you, and I'm really glad to hear that, all of that. It's and the fact that the understanding of that is embedded in children's services is really, really important, I think, because I think a lot of government agencies, you know, probably most of us here deal with things on behalf of our residents because they're not able to deal with things sometimes, or they don't know how to. And just a very quick example, you know, I was dealing with someone over, they got severe mental health issues after caring for their parents over a long period of time, and they're now at this point where they could be made homeless. And I'm trying to help them navigate, you know, a pathway through that. And a lot of their issues all happened during COVID, and the social isolation of this person all occurred during COVID. And I've been told by 2 government agencies, we no longer accept issues related to COVID as a reason for someone's issues. And that is just absolute, that's not children's services related, but that is just completely nuts, isn't it? Because it has affected.
I think, Councillor Price, we definitely all agree with you. That is just nuts. Councillor Adams.
I don't agree with Councillor Price. I don't think it's related to COVID, but it's another thing. I think some of it is. I think what I'd like to know, my main concern was, and Councillor Redrup raised my 2 issues were, the pupils with their special educational needs, 23%. That's high. That's nearly 1 in 4. Why is the reason for that? Do we know what the reason for that is? And how much of it is just plain and simply bad parenting? My other concern is, which Councillor Nicholson touched on earlier, and I think this is critical. I don't believe when the children come out of school, I don't believe they have any aspiration at all, because there's no jobs. How we address that and how we create them, I don't know. But there's no jobs, and there seems a total lack of aspiration.
And too many people to me seem today just to be quite happy to sit on whatever government allowance they're going to get and sit at home with their feet up. Something's wrong. How do we address it?
I would think very carefully how you answer that is my suggestion.
Councillor Adams, thank you for your question. So the number of children on the Isle of Wight who are registered as having a special educational need, whether they have an education or healthcare plan or don't, as I think we've already heard, is essentially the highest in the whole country. And there's a lot of work going on to work with our mainstream schools to support them in their ability to identify need early and prevent it from escalating. And that is linked to what you said about aspiration and the education strategy that we have. And we believe that as we work with our mainstream school colleagues to improve education standards, that will also result in a earlier identification of special education needs so that it doesn't escalate to a point where either it's registered as SEN support or the child needs an education or healthcare plan for their needs to be met. So there's a significant correlation nationally between the quality of overall mainstream education and the amount of special education needs and disabilities in that system if you equalise everything for socioeconomic situations. So if you look, for example, at our statistical neighbours and the amount of SEN that's prevalent in those neighbours' systems, there's a link with the quality of education in those schools and the amount of SEN that's identified.
Thank you. Joe, you wanted to come in here, and then I remind everybody we've got a question from Joanna, then Caroline will bring this section to a close. Joe.
I'll be quick and only really wanted to pick up on the word aspiration and your views around aspiration, and I can only talk about the work we do and what we find. So our hub team have gone into schools and have spoken to young people as part of careers events about their aspirations. We don't use that word, but what would they like to do for a job when they grow up? And there would appear to be no shortage of aspiration. Most of the young people that we speak to have something that they believe in, that they want to do. So that's the first thing I wanted to say. I think connected to aspiration, and sometimes I think perhaps muddies the water a little bit, is around confidence and self-esteem. Because I think there are a great many young people who do have aspiration, but don't have confidence and self-esteem. And the impact that that then has on them could appear as though they don't have aspiration. But I actually don't think it's that. I think it's the fact that they don't have any confidence or self-esteem.
I think you had a lot of people who were really nodding their heads and can relate to that. Thank you. Joanna.
Thank you. I was going to raise the point about the high levels of young people that self-harm. So I've worked for Healthwatch for nearly 11 years now. And in all those 11 years, we've had significantly higher numbers of young people that self-harm and present to hospital, either as an admission or through A&E. So in 11 years, that's been continuing. So I'd say whatever's going on is not working. 11 years is too long to see this trend continue. And it really concerns me about that statistic particularly. And I've got a question about how parents are supported. So I'd be doing a disservice to people that contact us if I didn't share some of their experiences. And we've had a significant number of parents contact us. Their child has significantly self-harmed. Some have attempted to take their lives, and the parents have been left managing that risk until they get to see a healthcare professional. And that could be days, that could be a week. And the parents are left not knowing how to support their child. And they're just spending their time trying to keep them safe. And that's a really difficult and challenging position for parents to be in. And I just wonder, you talked about risk management. How are parents involved in that process? And how are they supported to manage risks that essentially they're left with for a lot of the time?
Excellent question. Thank you. Callie?
So in terms of young people who would present at a hospital or in the community with high risk levels, we would work with that young person and their family, parents or carers, to think about what the risks are and how those risks can be managed. So clinicians with young people and parents would draw up risk management plans, safety plans, to think about in terms of what needs to be done to keep people safe, for example, looking away when medication, things like that. And then the team would work with the young person around skills in terms of de-escalation, how to manage thoughts of self-harm, thoughts of suicide, and complete quite comprehensive work with young people. We have a process in place, so if a young person was to present to children's A&E, they would be assessed by a psych liaison team who'd complete an assessment with the young person and liaise with parents. Assessment would be drawn up and a discharge plan would be in place. If that young person was deemed safe to be discharged to the community, CAMS would follow up with that young person within 3 days. Or if the young person was unsafe to be discharged to the community, they could be admitted to children's ward, and then CAMS would come up to the ward the next day to meet with that young person and the parents to talk about what support.
Thank you. I would say that the children's ward is not the best place for that young person to be if they're at risk of self-harm, because you don't have the specialist support there. So many parents would, and young people themselves would rather be at home, but I still think there's a gap between waiting for that support and their parents having to manage that risk.
I think in terms of children being admitted to children's ward, I think it depends on the needs of that child and their risk level. We've done quite a lot of work with children's ward and paediatric staff around managing children who've got mental health concerns. We also have a nurse who works between CAMS and also children's ward as well. So it's a split post. So she supports children ward staff thinking about mental health needs, and then also she supports our teams in terms of thinking about physical health needs. So that's just been in place probably for about a year now, and that's been working well. I also spoke about the holistic at home treatment team. So they work really intensively with families and can offer that support quite quickly, especially for children who've got eating disorders. So we always endeavour to keep children who've got an eating disorder at home in the community if we can, rather than having them on children's ward. And that team can do meal supervision and support, and also work with parents in terms of supporting them as well.
Lovely. So the last question will be for Councillor Gladwin. Thank you.
Well, my question is again about the self-harming with children. And I was just wondering why the levels of self-harming in children are so high, not only on the island, but also in Southampton and Hampshire. And on the rest of England, it's a lot lower. And so I was just wondering if is there anything we can actually be learning from the rest of England to address this, alarming situation? Thank you.
I think that's for you again, Callie.
Yeah. I think I think it's something that needs to be looked at in terms of why the levels are so high on the island compared to other places, because we obviously are working really hard on the Isle of Wight to think about how we can reduce the levels of self-harm. And I wonder if it is linked to because obviously we do have high levels of children who are in care. We've got high levels of children who've got EHCPs, who've got special educational needs. So it's thinking about the cohort of children we have on the Isle of Wight, and then thinking about how we can support better.
Thank you. Would anybody like to make a recommendation? Can make your recommendation, and Councillor Andre can make a recommendation.
I'd like to make a recommendation this council undertakes to develop a fit for purpose economic strategy that's led by somebody who's qualified and experienced. If they've got problems with getting somebody qualified and experienced, and I don't mean somebody who's come up from car parking, for example, then I could help them with links with Southampton University Innovation Centre, because I know they'd be very, very keen in helping the Isle of Wight develop a fit for purpose economic strategy, which tears down to all the other strategies. That's my proposal.
Thank you. And we will take Councillor Andre's recommendation as well.
Thank you, Chair. My recommendation is as follows. That priority is given by all partners to create a single point of contact for young people to be able to access mental health support services. Thank you.
Fantastic. Right, we'll do each one by turn. Is somebody quite happy to second Councillor Nicholson's recommendation?
Not necessarily second it, Chair. I just want to understand what the implication is by doing that. What do we mean in economic strategy? What for?
Councillor Fuller.
My question is, as members of the children's committee, are we entitled to vote, or are we here by invitation? Because again, we were told that it was a joint meeting.
It's fine. You are most entitled to vote. I've made
Brilliant. Thank you very much, Chair.
decision as the chair, and you can vote. It's only a recommendation. You can vote because they were voting. Have been invited to join this, and we have said in future, if it's something that's clunky in the constitution, then we'll add it to the list we need to look at in the constitution. This is the only committee that has a health scrutiny section. We had a discussion of chairs and vice chairs the other day, and it was agreed that actually we need to look that anybody from other committees that are relevant to this scrutiny section can be invited to join. At that point, I feel that if you've been asked to join by invite, then you should be entitled to have a vote. If we then want to rip the constitution up to pieces, and Laura's going to throw things at me, I think these are just recommendations. We're not making a decision on this. We're making a recommendation as the scrutiny section. What you wouldn't be able to do is if we were then talking further in the agenda, which you won't be attending that part of the meeting, that is a decision and a binding decision of this is, we are just talking about recommendations. Is that okay? Councillor Redrup.
Could I suggest that perhaps we direct it to a specific person? So like when we were doing it before in the scrutiny, we would direct it to the cabinet member, or we'd direct it to the leader, or direct it to a specific officer. Is there someone we can direct it to?
So I would have said with Councillor Nicholson's record, I get what he's saying about an economic strategy, and I get completely what Councillor Lever is saying. We have to remember this would be a recommendation to be looked at something that would have financial implications. So I just would slightly adapt your recommendation that this committee, as the scrutiny section of this committee, is recommending that we speak to the chief executive if such a economic strategy could be looked at, and could she then refer back to this committee. That way we're not making any financial decisions, we're not committing into anything. All we are asking is a general recommendation that could be looked at. Yeah.
I think it's important because we've been talking about young people. So I think it's important that if we're talking about an economic strategy and things, we're actually talking about helping young people have a better physical and mental well-being through a social economic. So I would like if you could actually add young people into it, it makes sense of this particular meeting.
It all tears down from there, Michael. That's the starting point. and any economist would tell you that. So I think what Claire's suggesting is
I think
it's
we'll
loose enough
yeah,
not to tie us up
word it
in
in
knots.
such a way, because we're not making a decision, we're just making a recommendation, and we do have time to move on. I'm quite happy to,
Just in respect of my recommendation, it is included in there that it is directed to all partners. So I think that covers off that
that's
element.
fine. I'm quite happy to second Councillor Nicholson if it is worded in such a way that it just goes to the Chief Executive to look if this is practicable. We're not making any financial decisions. So we'll vote on block for both of them. Is that okay? So I'm quite happy with both of the recommendations, quite happy to second them. Can we move to the vote, please? Is everybody happy with those two recommendations? Yes. Yeah. Thank you. Thank you, everybody, for your time. It was really appreciated. We did run over by quite a bit, but it was a huge section of the agenda. Thank you for your time. I'll let you clear up to, don't have to sit through the rest of it. It's absolutely fine. And we will move to the second part of the agenda, which is an actual decision. So I'm hoping you have all read your papers. I will chair this section of the meeting till 7 o'clock, and then because of prior commitments, and I did check and double check that my vice chair was happy with this, I will be leaving and handing over to the vice chair. So I will chair till 7 o'clock. And for decision A, the contract award, I hand over to Laura Gordian.
Thank you, Chair. My assumption is that all committee members have had the opportunity to read the report. The report before you relates to the tender of background care and support within supported living services on the Isle of Wight for adults with a learning disability. It relates to 9 separate services supporting 49 different individuals with learning disabilities and complex needs. The council has been undertaking a standard but robust procurement process over the last few months, and the recommendation is that the committee acknowledges and endorses the re-tendering of this contract through the application of a full and compliant procurement process, and that the committee delegates authority to me as the Strategic Director for Adult Social Care and Housing to award the contract to the successful bidder. I'm happy to answer any questions that you may have in relation to the report or the content of it. What I would say is at this stage, I'm unable to confirm to you the identity of the successful bidder. This process remains commercially sensitive still, and until the contract is awarded, that information cannot be shared publicly.
And before I go into that and let Councillor Nicholas ask a question, I do have to add we are going to rerun the procurement training. It was absolutely excellent. It was really, really good. It needs slightly longer than we had, but now you're having to make decisions rather than scrutinise. You're making decisions on really big contracts like this. I am going to make sure that everybody, all councillors, have had an offer to re-attend that training. Councillor Nichols.
Can I take a guess and say that this report was written by you, Laura?
The report was written by one of my officers. It's been overseen by me and it's presented by me.
What can I say? What an excellent report it is. It's to the point, informative, and there's everything you need to know in there. So really, really impressed with it. Thank you.
Councillor Oliver.
Yeah, can I just ask some clarification? You've got the properties situated in the 5 towns. Can I ask how many properties you have got in the 5 towns? Is that something you're aware of? And also, it's how many staff are actually affected with this, in loss of potential jobs and that within the procurement process?
So in terms of the number of properties, in total, we're talking about 9 properties across this contract award. The council may or may not know additional properties. I'm only focusing on the supported living properties that are subject to this report. And in terms of any job losses, in the council's procurement process, we implement the transfer of undertakings regulations, so there are no planned job cuts. As a result, employees within the existing service, Keys Group, will transfer to the new provider, and for the one property, which is a local authority run residential care home, those staff will also transfer or be given the option to transfer to that new provider. redundancies aren't planned as part of this process. I'm afraid I can't help you with the total number of staff because they aren't all our staff. So that information isn't available to me. It is available to any potential new supplier as part of the tender process.
Yeah, also, could I, is Keys Group are, the existing provider, is there any reason why they actually decided not to carry forward?
As with all council contracts, they're tendered for a specific period of time. That contract ends, lapses, terminates, and we have a requirement to continue to re-procure those services. It's no reflection on the performance of that provider. We've been very happy with the service that we've received, and they were given the opportunity to participate and re-tender for these services.
Councillor Andre.
Thank you, Chair. So we heard a lot previously about how the service needs to be needs driven. And I think that is very obvious in this paper, that the focus is very much on the individual. And I know through having visited, well, Saxonbury and all of our residential places, that these are homes for people that it's their family. It means an awful lot to them. So how are we going to be working proactively to prepare these individuals, really more focused, I suppose, on Saxonbury, because they're going to have the greatest change? How are we going to be working proactively to prepare them for as calm a transition to whatever new arrangement is determined? Thank you.
Councillor Andre, thank you. And I'm really grateful to you for the question you've asked. My priority, and I've made no bones about it for all the time I've been in this service, is supporting the people that I'm here to serve in the best way I possibly can. I have to make tough decisions, and those tough decisions don't always sit well with me. We have limited resources, and we have a limited way in which we can help people. Where a person is eligible for our care and support, I have a statutory duty to meet their needs. It's no different wherever they live within our community and whichever type of support they receive. As a provider, I wear a very different hat. And as a provider with responsibility for the Adelaide, for the Gouldings, for our internal outreach services, for Westminster House, for Pleading, and for Saxonbury, those folk are my folk, and it's my duty to make sure that not only do we discharge our statutory duties under the Care Act, I discharge my duties as their care provider. We are not operating a one-size-fits-all process within this transfer to a new provider. And as you rightly draw out, for the folk at Saxonbury, there could be a significant change in terms of how their care and support is delivered. We've been working with those individuals, with their advocates, with the staff who know them really well, and with families where they have families who are supporting them, to make sure that their views and their wishes are incorporated into our decision-making process. There'll be a gradual introduction to a new provider. Because the staff will transfer, they will remain in contact with the same people who they've grown to know to provide their care and support. Saxonbury is a relatively small home. We're currently carrying a number of vacancies, and the people who live there are quite involved in their local communities and active across the island. So now really is the right time to help them move to a greater level of independence, to having their fundamental rights of citizenship. At the moment, they don't have a key to their own front door. They're a guest within the place that they call home. Helping them to really benefit from their own home is part of what this transformation is about. So I can assure you that my team are in place to support those individuals, the workers, the carers, the providers who've been with them for as long as they've been in that home, continue to be with them, and we'll make that transition as smooth as possible. I can't promise it will go without a hiccup. It's not my first rodeo, and I've been around the deregistration of residential services and the setting up of supported living services a number of times. Nothing is ever problem free, but we are aware of what those problems are likely to be, and we're preparing to mitigate any issues in that regard.
Councillor Redrup.
Thank you, Chair. My question was about future proofing for the contract. So it's it's quite different to what it was before. And I was pleased to see that there's a period of 2 years where it's fixed, and then the new provider has an opportunity to give a business case, which they're probably quite grateful for, considering the changes to minimum wage and also employees' national insurance can be a bit unpredictable, and we don't know what that's going to look like in the next 2 years. I see under the additional 1-to-1 hours, it's at £18 per hour. So considering at the moment I'm not saying that the staff will be paid minimum wage, but if you were to go off of that as a sort of baseline, the true cost is around £14 per hour, taking into consideration the other payroll costs. So it's probably fair to assume that after the 2 years there will be some increases, and it's likely they will come with a business case because of increased costs. At that point, if there is, are you confident that you can work with that new provider to come to an agreement at that stage? If there is an agreement and the new provider wants something more than the council can offer, what happens at that point? Thanks.
In relation to this contract, that's a new position. In relation to the way in which we buy care and support services, that's an annual dance that we undertake with our private sector partners on a very regular basis. With relation to the 1-to-1 hours, the core costs of delivering the services are built into the main contract cost. So they really are just staffing costs for that 1-to-1 support. So we're satisfied that that does not only meet national living wage standards, but enable a higher rate of remuneration for what is a really skilled and professional job that people are undertaking. We chose with this contract to build in the ability to negotiate with the provider in a way that we haven't before, reflecting on the pressures we've seen for social care workforce and for providers meeting those workforce costs over the last 6 years. The growth in national living wage, the growth in pension contributions, changes in 0-hour contracts, and the impact we've seen from the national insurance changes has really hit independent sector providers and care providers very hard. And what we don't want to be is in a position where in a couple of years from now, we've got a contract that's being handed back because it's no longer affordable to the provider. The change in the way in which we're buying the service gives us scope to negotiate with that person, but equally it gives us scope through our council budget setting processes to make sure we've got the right systems in place to support any uplift in provider fee at that point in time. So I'm confident that what we've built in is the right contract approach for this rather large service with a rather large budget envelope over its total lifetime. Ensuring we achieve best value for the local authority, but ensuring we discharge our Care Act duties and enable the people who are delivering the service to operate in a fair way with their staff.
Do we have any further questions? Councillor.
Chairman, I have confidence in accepting the recommendation being made for us, and I'd like to go to the vote.
So I'll just read the recommendation that the committee acknowledges and endorses the retendering of this contract through the application of a full and compliant procurement process, that the committee delegates authority to the strategic director of adult social care to award the contract to the successful bidder. Are we happy to move to the vote? So we have a majority. Do we have any abstentions? One abstention. We are happy to do that. Thank you. I think as a time it will be quite wise to hand over to yourself now, and then I will slip out at 7. Do you want to swap seats? Are you fine? Okay. Okay, thank you. We'll move on to item 7B, which is service performance and improvement Q1. And is that yourself again reporting? I'll pass over to you, Laura.
Thank you, new chair. In terms of this report, before I lead you through the information that's been provided, there are 3 errors which I wish to correct, and I apologise most sincerely for those. In endeavouring to provide you with the most up-to-date information, the report was drafted back at the beginning of June so that it could go through our quality assurance processes, through the corporate management team, and then to be presented in time to be published to you. What I'm hoping you've already noticed is that the report itself at paragraph 11 and 12 contains information that doesn't actually reflect what's contained in the appendix. The appendix has for you the June figures and data, so that is the most up-to-date position. But paragraph 11 references the May figure, and paragraph 12 for adult social care, and paragraph 12 references the May figure for housing. So the information within the appendix is the correct information, and it's purely a time lag. I will try harder and I must do better. The other error you will find is one that's been created by technology. It isn't an error in the published version online, but in a paper copy if you have one. KPI 18 relating to the adult social care and housing financial needs position in the printed version is not showing correctly as thousands. It really is thousands, not just single digits. It has been corrected in the electronic version, and we've managed to correct the template so that won't pull through when you see this report again in the future. So just to clarify those 3 errors for you in the report. The report itself is a first try for me. I was determined and discussed with Councillor Mosdell as your chair the need for this committee to be making decisions fully informed by the current position of adult social care and housing needs. If I rely on the information you receive through our old QPMR process, you'd probably be getting my May data around about September. And when I'm asking you to make such big decisions which affect such significant areas and large numbers of our population here on the island, I think it's really important that you are cited in a fully transparent way on how my directorate and I am performing in discharging our duties. I wanted to provide you with information in relation to our performance and the key performance indicators that currently are in place that were refreshed in April of this year, in relation to the core risks that I'm managing across the directorate, and in relation to our budget. I like to think that the first 2 are better news than the last one, although I want to provide you with reassurance that the last one is probably the area that I monitor most closely. I don't propose to take you through the report. It is as set out. The key risks are there for you. The key performance data is there for you. But I am very happy to take any questions you have and to answer any concerns that this report brought up for you that you'd like me to explain to you.
I'll just take Claire's question first and then yours.
Thank you. It's a question that I know the answer to, but I actually think it's quite important that it goes out into a public domain. So it's housing need and homelessness. Reported is the number of rough sleepers is 7. If you put that into the public domain, people will say, well, I see far more people sleeping in tents and things like that. So I'd like more of an explanation of how you get to the 7. And just a little bit more on, it's good to see that there is no children currently in bed and breakfast over 6 weeks. Can we just have some assurance that is being done correctly now, as there was an issue in how that data was collected in the past and movements, etc. So just, it's 2 questions really. Thank you.
In relation to first, in terms of the rough sleeping data that we collect, that's rough sleeping, street homeless people rather than homelessness. The count is based on a specific night and a snapshot in time. We commission an outreach service, and the outreach service together with my staff undertake that count. We can only count the people that we find on that day. What we are very committed to is ensuring that everyone, every single person who's within that cohort has an offer of accommodation to support them. And that remains the overarching commitment from my service. They may not choose to take up that offer, and we can't force them to do so, but that offer needs to be there, and we need to ensure that people know they've got a safe place to go. Where we don't owe somebody a statutory duty to provide housing, we sometimes fall into a bit of a pickle. And that is more often than not the cases that become more public, where a person's homelessness is intentional. As a council, we have no duty to meet that need. I do have discretion in that area, and we currently accommodate a number of people based on our discretion, because although technically they are intentionally homeless, there is evidence that shows that's a technicality rather than a factual position, and we support them to secure their own accommodation and to move them on. But in the interim, we manage that risk collectively with our partners to ensure that those people are safe. In relation to your second question around people, families, children in bed and breakfast, I can confirm that at this stage that is 0. That is absolutely correct. It's an area that I am very cited on, and Councillor Mosdell alluded to a bit of jiggery pokery that took place in the past. Historically, local authorities have moved people. So there's been a family in bed and breakfast accommodation. We don't want to report it, so we move them somewhere else for 5 more weeks and then we move them back. This local authority does not practice in that way. You can have confidence that when I tell you there are no children in bed and breakfast more than 6 weeks, there really are no children in bed and breakfast more than 6 weeks. I cannot guarantee you that that will be the position every single time I bring this report. But if there is a child in bed and breakfast for longer than 6 weeks, what I can guarantee you is I know about it and there's a plan in place to help that family, that young person, move on as quickly as possible.
Councillor Lever.
Thank you, Chair. But firstly, Laura, really like the report, the way it's set out, very easy to digest, so thank you. I think the only thing that then I was trying to understand was with some of the figures, so for example, the number of people waiting for assessments in terms of adult social care assessment waiting list, I was then just curious of in terms of how long on average that people are waiting for an assessment. So of the people that are in that new number, so 1650, how many of them are the same people that were in the previous number? And the same kind of applies in terms of, I don't know, number of rough sleepers. So 8 in the same month last year, 7 now. How many of them are the same people? Yeah.
That's really tricky for me to monitor. And what I can tell you is in terms of the people waiting for assessment, it depends on the type of assessment. So if we take the 4 boxes below, at the moment, I've got 197 people awaiting their DOLS assessment. Of that 197, without exception, none of them would have been waiting more than a few months. So there is high turnover in that area. We get on average about 90 DOLS assessments a month. There is a big process that sits behind that that does take time, but there's high turnover in terms of our DOLS assessment, and I'm confident that that area is being regularly maintained in those numbers. Ideally, if I could get that down to 80 every time you see the report, I'd be a very happy Laura. But I'm conscious that sometimes there are delays in that area linked to availability of people to undertake assessments and families and individuals to engage in those assessments. So that's part of that process. In terms of the financial assessment position, again, similar story. Our current turnaround time for financial assessment is less than 7 days. So although there are 70 people waiting for a financial assessment at the moment, I would anticipate that none of those had been waiting more than a month. If there is a delay in a financial assessment, it's because we're waiting for information to be provided by the individual or by their family, and sometimes they need support to do that. So we may need to arrange to go out and meet with them or for them to meet with their solicitors, so we can see some lag in that area. Occupational therapy is very different, and occupational therapy for me is a significant area of risk across the service. It's not unusual for a person to wait upwards of a year, 18 months for their occupational therapy assessment. That's largely linked to the way in which occupational therapy is now within the council. For a significant period of time and pre the end of 2023, that service was outsourced. It came back into the council's world in October, and with it, it came a waiting list. In relation to those occupational therapy assessments and to address the concerns I had around those waiting lists, I invited the Chief Internal Auditor and her team to audit that service area for us. That audit was undertaken earlier this year, and as a result, a robust action plan, a service improvement plan, is now in place to start addressing those waits and those issues. Each of those 501 people has been risk assessed through a RAG rating system. We have triage at our front door, and those who are in higher priority, our red cohort of people, on occasions a very red person, will be picked up as a priority. The majority of the assessments that are waiting there are waiting for low level assessment, and we're looking at alternatives, including self-service and use of assistive technology to help divert some of that demand to a place where people can support themselves. I always use the sponge on a stick example. If you're told you need an occupational therapist because you can't wash your back, you go to an occupational therapist and you have an assessment. It might be that actually the solution the occupational therapist is going to give you is nip down to Poundland and buy a sponge on a stick. If we can tell them to get a sponge on a stick at the point they come to us, for that person, their journey is much shorter, the intervention much easier, and their quality of life is significantly improved. Waiting on a waiting list for me and me saying, I'll be with you shortly, you're not a priority. So a huge piece of work to transform the way in which we offer occupational therapy in a less traditional way to our services. We've already gone a step towards that by changing the way in which our occupational therapy service is built. We always used to say, oh no, you've got to be an occupational therapist. But we've looked at a real mix of skills, and we've now got occupational therapy assistants, and we've employed our first apprentice OT this year. So we're looking to build on a grow our own service. We found it hard to recruit, as did the people we outsourced to, which is probably why we ended up inheriting a waiting list in that area. So very actively managing that piece of work. In relation to the annual reviews, we got that figure right down. And then because they're annual, at this time of year, it goes right up again. And then it will come back down again. And then at this time of next year, it will come back up again. We've changed the way we look at how we manage our annual reviews. I've now got a reviewing team who are pulling forward some of those annual reviews so that we can stagger them, plan that activity in a different way. And what we see with some people is there'll be a change of their need within the year, but we don't update their record. So we might have seen them 6 weeks ago, but we're still saying their annual review is overdue because we've not done that particular piece of work. It no longer needs doing, it can be redated. So a lot of data cleansing activity in that area. Of those 760, we're probably doing about 50 overdue reviews each month. So we are not seeing the same people on the list. I've got a couple of people whose reviews are overdue for more than 2 years. However, I'm satisfied that there's good reason for that and it's a justified need. Annual reviews can be delayed for any number of reasons. We know that we have a lot of people who live here whose families don't. And as part of our reviewing activity, and to be truly person-centred, what we like to do is involve relatives, families, advocates, making sure people have somebody to speak on their behalf. And sometimes that means we arrange a review and the family can't make it and we have to wait till they're able to get time off work and come to the Isle of Wight to participate. We've recently started using MS Teams as an option to mean the family don't have to travel, and that's taken some time to support local people to get used to, because whilst their family might be tech savvy, they're slightly confused by what's going on. So we need to be able to roll that out in a controlled way. I suspect this time next year I'll be sat with you with a relatively similar figure to that 760. But come January, I'd suspect I'd be sat here with a much lower figure, because by then we'll see the peaks and the troughs in that area. So different elements of our wait list operate in different ways. There is full oversight in relation to each of those on a monthly basis through my service management processes and through my leadership team. And I'm satisfied that where we need improvement plans, those improvement plans have been put in place. I've invited our internal auditors to come back in September to re-audit occupational therapy so that I can provide greater levels of assurance in terms of our progress.
Thank you, Laura. Councillor Glavin.
Yeah, I was just interested, looking at the graph of number of people living independently at home supported by ASC, and it goes for in February from a very high number, and it has a sharp drop in March, and I was just wondering why that was. Thank you.
There are always a number of reasons, and people exit my service in a variety of different ways. What we tend to find is when it's very cold, there is an impact on individuals' abilities to remain independent in their own home as long. And what we see at that time of year is people exiting the services through a variety of those different means. Some may have died, some may have moved to residential care or to nursing care where their needs can be better met. But equally, during that period of time, what we see is a higher number of people being discharged from hospital, receiving reablement care in their own homes. the whole purpose of reablement care is to rebuild their independence, to support them to maintain that moving forward. And that peak we see over the Christmas period of people coming into that service tends to dwindle towards February, March time. So a whole variety of different reasons, largely seasonal, I'd suggest.
Councillor Nicholson.
Yeah. This report is an example of a report that is starkly open and honest. Everything is straightforward. And since I've known Laura, I have to say that she's remarkable in displaying the level of competence. She is a really competent officer who I think deserves our trust and respect. And I've every confidence that the data in this report will be used for good management, Laura. I really wish to commend you on the effort you put into this council. I think it's exemplary.
Councillor Andre.
Thank you, Chair. My question focuses on households in temporary accommodation. I know that we commission a variety of accommodations in that area and providers, because I have quite a few in my ward. The figure 91 households 2 to 5 years is of particular concern to me. And I know that we're talking about households here, and a lot of those are families with children. We've heard what effect housing and environment has on parents and children. Is there any work ongoing that we are looking at any other initiatives of things that I'm sure that there might be best practice, things that are going on elsewhere? I know that it's maybe connected, but things like shared lives. Is there any work ongoing with that? And are there any initiatives that we haven't actually looked at or embraced so far that could actually relieve that? Because I accept we do need temporary accommodation, but I think there are other ways that perhaps we could deliver it that would work better for our island residents.
Absolutely. And I've got to be very careful not to get overexcited at this point in time. And we're joined on screen by my particularly awesome service director for housing needs. And I am so lucky to have the support of Dawn. Dawn's enthusiasm knows no bounds in terms of getting us to the place we need to be in relation to housing, and the effort her and her team put in to looking at alternatives to support people in better quality temporary accommodation is second to none. You are obviously aware we've recently bought 15 units of temporary accommodation ourselves in God's Hill. You may not be aware we've also bought 5 units of accommodation in an HMO. Dawn is currently working on a programme to build units of accommodation for veterans, and we are in the process of, or have, or will shortly also be securing units of accommodation through stock transfer. So we're looking to really build the accommodation within the local authority's control to support people who need temporary or emergency accommodation. The reason for that is a commitment that Dawn and I share. The quality of our temporary accommodation needs to improve. We can't be in a position where our temporary accommodation falls below the standard that we feel and genuinely believe is acceptable for any member of our community. We know locally we've not seen a lot of building from our registered providers, and that's why we've seen an increase in temporary accommodation use. People have got nowhere to move to. Historically, they may have moved into private rented accommodation, but again, that market has become constrained. So along with discharging our duties in relation to housing needs, those statutory duties we have, Dawn and the team work really closely with colleagues across the council to identify how the housing needs can be met through the activity that they have responsibility for. We've got an officer group, our property action group, where we meet regularly with finance colleagues, legal colleagues, planners, our own property services team, to really focus on what we can do to better support people. And earlier this year, we launched our housing needs market position statement. If you've not seen it, you'll find it on our website. And what it does is pull through the housing needs data. So if there's any developer out there who thinks, I want to build on the island to support whoever, it will tell them where people want houses, what size houses, the type of demand in that area, where people don't want houses and why they don't want them there. But also it gives information around the average spend of households, what's affordable, both in terms of owned and in terms of rented. So it gives a far fuller picture to people who are looking to invest in building permanent accommodation, move on accommodation for the people we have in temporary accommodation as an island. It's been really well received. I met with the architects and agents group. Ollie Bolter chairs that group, and I was very lucky to get an invitation. And then I had a barrage of people emailing me saying, what about this plan? What about that plan? How does this work? So it certainly started conversations, and I'm hopeful that we're starting to see some benefit of that. Dawn works really closely with a number of registered providers. She links in with them on a regular basis in terms of potential options for our land, for land that we know is out there, or where they're contemplating doing things with their own land, to make sure that what we get is what we need. And we've seen that up at Horsebridge Hill. At Horsebridge Hill, there are 4 properties that are replacing 3 blocks of flats that we knew we didn't have a use for. Those 4 properties plus 10 shared ownership properties, which will be available to the open market to buy, help us with a challenge around large households. We know we've got some big families on the Isle of Wight, and those big families aren't going to fit in your average 3-bedroom house. We've needed to look at how we can diversify the stock that registered providers have to better accommodate them. On average, we've got 5 large families that we need to accommodate at any point in time. We've got 4 units coming on board that sleep 6, 7 and 8 people. That seriously helps move on some of those 26 people in the 5+ years, but creates a new model for us as a local authority to support people in a better way moving forward. Those aren't temporary units, those are permanent social landlord units that will be a home for those individuals. Aligned with that, Dawn's been working with the registered providers around right sizing accommodation, where we've got big families who fly the nest and we end up with just mum and dad, or mum or dad, or mum and nan living in a property with 5 bedrooms. They don't need that. So through Dawn's work with the registered providers, we're helping to move those people somewhere else into a more suitable size property so that we can reuse that bigger property. On occasions, we're able to get 3 or 4 moves out of a single property becoming available. 3 or 4 households moving into accommodation that's suitable to meet their needs when actually we've only got 1 more house. So quite a critical piece of work that really does make a difference for local people. In an ideal world, I'd love to see loads more houses, but I completely understand the challenges connected with that. And I understand that that's not my decision to make.
Thank you. Any other questions? Oh, sorry. Yeah, go ahead.
Could you give us an example of stock transfer?
Yeah, of course. There's 3 that we're working on at the moment, and I'm hoping I'm not breaching confidentiality in relation to the latter one. As far as I'm aware, the residents are aware. If you know the Adelaide care home, I'm watching for Dawn's hand flying up if I'm not allowed to say anything. Next door to the Adelaide care home, there are a number of independent flats. Our staff at the Adelaide support the call bell systems, the fire alarms, and provide care and support into those flats, but they're owned and operated by Sovereign. They no longer wish to provide that service, and for us, what that does is provide us with units of accommodation for people who don't meet a need for residential care but could do with perhaps a bit more support. Stock transfers come with the tenants that they already have, and we continue to support those tenants, but as those units become vacant, they add to the stock that we as an authority have available to us. I think in total, if memory serves me correctly, on a stock transfer point of view over last financial year and this financial year, we're close to bringing into our service an additional 20 units of accommodation.
Thank you. Laura, I had a question about the overspend and underspend. I'll start with the overspend. I was wondering I was wondering how this compares to last year. Is this significant? I tried to find it out. I'm sorry I couldn't, but I'm wondering whether you might have it to hand. How it compares to last year. Is it significantly more or less, and why that might be?
So it's actually about the same. And next year, when you try to find out, you'll have this report available to support you. So I think that's a really positive step forward in terms of that openness and transparency. My overspend across both areas of my service is driven by demand. I said to you earlier, if there is a need that's assessed, I have to meet it. And I have to meet it in the most cost-effective way that I can, but also promoting choice and control for the individual. So that can sometimes get expensive, and the needs of individuals dictate how much it costs me. We set our budget through full council, and every year I go into the year with a gap in my budget. So the budget that's made available to me is not sufficient to meet the need that I know I have at the outset of the year. Through that budget process, I have a number of not savings targets, but mitigations that I have to put in place to try and make the budget align with the activity. Some are successful, some aren't successful, and some are delivered earlier in the year and some take longer to deliver. So at this point in time, I'm exactly where I expected to be. Not happy about it. I'll never be happy all the time. There's an overspend there and it does need robustly managing, but we put in systems in place to ensure that that happens. And just to give you one indication of a system, for people's needs to be assessed effectively, we need to ensure that we're delivering a quality service. We put in place a forum, which is our Pride in Practice forum, which looks at the assessment of eligibility. Aligned to that assessment of eligibility, we calculate the personal budget that every person gets. Now, that personal budget isn't necessarily given to them. We can spend it on their behalf through our commission services, but we give them that choice as well. For every Pride in Practice referral that exceeds our standard care bands, it comes to me for a decision. So anything out of the ordinary, anything that is more expensive than we were anticipating, but more importantly, where a person has a complex need, it comes to me. My job is to look at the need itself and how we're proposing to meet that need, and to assure myself that the personal budget that's allocated is appropriate to meet that need. It's not a funding panel, it's not a budget exercise, it's about need and how we meet it. That gives me the ability to sit before you today and to say, without exception, I am satisfied that where we have complex needs, those needs are being met appropriately. If somebody presents with a complex need that, for example, needs 2 carers to support them every single hour of every single day, my question back to my team is why? What are those 2 carers doing? How is that supporting that person to meet their outcomes? I wouldn't want to be sat in a chair and have 2 people watching me 24 hours a day. I don't think that would help with my mental health and my well-being. There must be a purpose to it. And the purpose we look to deliver is the least restrictive for the individual, which may mean that actually they only need 2 people between 6 o'clock and 9 o'clock at night, because we know that that's when their medication is wearing off and that's when behaviours are heightened. It's that level of detail that we're looking at in terms of how personal budgets are allocated and what care and support people receive. Throughout the course of the year, those larger, more complex care and support needs are reviewed on a more regular basis. So we know that we're right sizing that care and support for the individual, not getting too much, but equally their needs are being met and they're not getting too little. In that space, we work really hard with our independent sector partners. with the care and support providers to understand what the average day looks like for that person and how we can support to make it better. My job isn't just to help people to survive, it's to help people to thrive. And in that space, we get the opportunity to make some real difference.
Thank you. And I'll ask, probably a bit briefer, is on the underspend. So it's only a small underspend. And I just wanted to ask what happens when you have an underspend? Do you direct it towards something else, or does it just roll in and there's an overspend another time? Thank you.
I squirrel it away in anticipation of an overspend.
Any other questions? We will move to the recommendation, which I'm scrolling up to find. Here we are. So the recommendation is that the committee notes the operational and financial performance of the Adult Social Care and Housing Needs Directorate. Can I take a seconder? Yes. And those in favour? Thank you. And that's that. Thank you very much. Okay, for the last point on the agenda is the committee work plan. Yes, Councillor Nicholson?
This is, yeah, I'd like to add an item to the scrutiny element, which is ICB communications. Two elements. One is compliance and enforcement of compliance with commissioned services in accessibility, because I don't believe that the large print or the absence of large print and other accessible considerations has gone away from the previous scrutiny committee. The second element is that that the ICB are contactable, and that means that when somebody rings in, a person answers the phone, that they respond to that person's question, and they're accountable to public access. Because I believe from research that one of our residents has carried out, that they are unique in that not being the case. So I'd just like to prove that if possible.
Thank you. So we've got 1, 2, 3, 4. I'm counting right. 4 health scrutiny topics before next year. So there's definitely space for something like that. Councillor Andre.
Thank you, Chair, and that feeds in very nicely to my suggestions. So I've been reading the Health Watch intelligence report. Thanks for that, Joe. It's always really so clearly set out, and I think it very ably demonstrates from our residents' point of view where the concerns lie. And I think that would be a useful focus for us for our health scrutiny. So the two main most common feedback topics from the May-June intelligence report were palliative care and GP services. I have a question for Joe, because I know that you're going to be publishing a separate report on the palliative services. Have you any idea of when that's likely to be? Because it would be really good, wouldn't it, if we could tie that in with our scrutiny.
So the palliative care report is based around the substantial amount of feedback we've had around the funding cuts to Mountbatten. And as we've done in the past, if we get a significant amount of feedback about one service, we'll do a separate thematic report to reflect people's concerns at the time. We've had a huge amount of people write to us, ring us, email us, complete our web form with concerns about potential cuts. We've had people with stage 4 cancer contact us that are really concerned about their future care. So we feel obliged to just do a thematic report on that, and we hope to produce it within the next 2 or 3 weeks.
Oh, okay.
And
So-
we'll share that with commissioners, and it will be published as well. Regarding the GP work, again, this month, GP access, I believe, will be top of the list of the reasons people contact us. So we're doing a piece of work at the moment, reviewing all the access arrangements for each GP practice, because they are very different. So every GP practice uses a different system and has a different appointment system. So some GP practices you can pre-book appointments, some you can't. Some use e-consult, some use Rapid Health, some use WhatsApp, some use AI triage. They're all very different systems. So we're going to review them and reflect that against the feedback we get around those systems to look at where the gaps are.
Sorry, Joe, could we actually call in the practice managers? Because when you look at the table, there's consistent poor performance from specific practices, and that's been going on for years. And I do feel that if we got the power, we ought to call in the practice managers to hold them to account.
Just to mention, the National GP Patient Survey results were published recently, and those results, although there were relatively small amounts of numbers of people that completed the survey, they do reflect the feedback that we're getting about those practices. And clearly there are some practices that are delivering a really good service and access is good. And there are some practices that are not delivering a good service and where it's very difficult to get access. And as we always say, it's the inequality across the island that's the problem. If you live in a certain town, you've got really good access. If you live somewhere else on the island, there's poor access and it's just not good enough and it's not fair. And some groups of people are being left behind as well around access. So we're doing a piece of work on that at the moment.
So perhaps, Chair, I could suggest, I don't know what the timing of your suggestion, Councillor Nicholson, but I would think possibly the palliative care one for our September meeting and GPs for the October, the health scrutiny element.
Whatever, but I think surgeries, but it still hasn't fixed it. So I think we need to have greater impact. Go with whatever you say, Debbie.
I think, Chair, I think there is actually a group of GPs that meet. I'll look into it. I'm pretty sure that there is a group from, so there's basically a designated person from the 16 practices, isn't there? So I think if we could get either a representative, but we've had representatives. We've had somebody from the Newport practice, I know, that has come in, practice manager, so I'm sure that could be arranged. But I think that would be really good because, as Councillor Nicholson says, I think there have been some quite major changes in the way that access to GP surgeries, but it's not necessarily been an improvement. So I think it would be really good.
Sorry, I just wanted to mention that the NHS Foundation Trust have made contact asking to come to the committee at some point. Obviously, they're the organisation now that runs the mental health section for the island and Hampshire. So factoring in that as well as to which is the priority and when you want it to come would be appreciated.
We instead of taking up committee time during a committee session, because that's informative, and I think we need to be informed where they are. But couldn't they put something on at the boardroom at the hospital and invite us up there with a cup of tea?
I mean, I think they're based over on the mainland. Yeah, I can reach out to them and ask for a briefing rather than coming to.
I wonder whether the committee may wish to add a report for noting to its main decision-making part, not scrutiny, in relation to the Care Quality Commission's assurance of adult social care. I wrote to you all to update you. We have received the information request. We're working through that. Death by documents, I think, is the phrase I used this morning as we were working through it. That will be submitted by the 1st of August. I'm anticipating that the Care Quality Committee will respond to that and will give us a date for when they're coming. So I'd like, if possible, to add to your agenda the opportunity to share with you our self-assessment again, but also to update you in relation to where we are with preparations and what we're anticipating. I do appreciate that could be an informal briefing, but given the gravity of that process, I'd rather that was something we were able to discuss in public so that island residents have the opportunity to hear those discussions.
I just realised I skipped over you, Councillor Price.
That's fine, Chairman. No, it was only just to sort of mention the two things that Councillor Nicholson mentioned, because you know, something as simple as larger print is so important to some of our partially sighted residents. It's been years, and you know, there's so many departments that can just do it with the press of a button, and there's others that refuse to do it. Whether it's their system that can't produce larger print or whatever it is, it just seems absolutely nuts in this day and age of technology that you can't provide larger print to partially sighted people. That's something we definitely should bring up with the relevant party. Thank you.
Yeah, Joanna.
Can I just add to that the new accessible information standards were published 30th June. So we've now got updated standards and slightly revised standards. And also to mention, we did some work on this a couple of years ago. And as a result, the ICB have set up 4 working groups around the accessible information standards. So I sit on the awareness raising one, and I've requested that all trusts put some information on their websites about people's rights under the AIS. And it took the new Community and Mental Health Trust a week, and they've done it. And they've got a wonderful piece on their website around the accessible information. So we've started, but we need to go much further. So absolutely agree, it's fundamental to people getting the health and care they need.
And it's also relevant to the NHS's new 10-year plan as well, especially with digitisation. I use the NHS app quite frequently, and if you've got the right settings, you can have that on big print on your phone as well. So it sort of bypasses the need for print if you're able to use a mobile device, but not everything is on there. And I know that when we've spoken to them before about it, it's about these multiple layers of different systems, which I'm glad the NHS are finally realising needs to be addressed through their 10-year plan. So it seems like there has been meaningful change since we last spoke about it. So it would be useful to speak about it again. Anyone got anything else to do with the work plan? Yes, Mel.
Just asking for confirmation really of what would you like the next topic to be on in September specifically, so that we can look to arranging that. Yes, for the scrutiny.
I think with the timing with Mountbatten and your report, I think the palliative care, does the committee agree? Yeah. Would we need to ask Claire for her thoughts on this as she's not here? It'd be good. So could we say that we have suggested that, and then we'll get Claire's feedback as well? Yeah, wonderful. And then the other recommendations are GP access, NHS Foundation Trust briefing, and ICB and accessibility information, and communications. And then the CQC reports as one of the main agenda items. Is there anything else that anyone can think of at this time? Okay, thank you. We will bring the meeting to a close. Thank you, everyone. Thank you very much. Thank you, Laura. Thank you, Mel. Megan. Thank you, Joe.